Good afternoon, everyone. I think quite a bit of interesting questions that I was actually supposed to ask during my panel discussion have been covered in Dr. Shaina's talk also. So I may need your help. Whatever in additional questions, if you have that coming to your mind, please feel free to interact. So I'm going to discuss about the abstracts that were presented in relation to triple negative breast cancer just prior to Dr. Shaina's talk. Now these are the panelists, we are already there. So I'm going to start with a case first. This was a 52-year-old female. She had no comorbidities. There was no family history of breast cancer or other malignancies. She presented with a lump in right breast of about 4.5 centimeter. PET scan showed a non-metastatic disease and biopsy showed a IDC which was grade 3. Now a biopsy was done and these are the pathology reports. The first one is reported by a pathologist 1 who reported this, and these are the actual reports, so I am not cooking up the case. So this was ER positive, 10% nuclear staining, intensity was weak, and all-red score was 3/8, PR was negative, HER2/neu was negative, Ki67 was reported at 60 to 70%. The same pathology report was reviewed by another pathologist who reported this as triple negative and Ki67 of 29%. And as you can see from the report, the internal controls were satisfactory for ER and PR. For HER2/neu, the external controls were also satisfactory. Now, we see a spectrum of patients in our practice. We have on your left-hand side the spectrum of triple negative breast cancer where ER, PR are all three negative. On the other end is the so-called triple positive where all three are positive. But in between, we have patients who have expression of just PR or who are low in HER2/neu, and we know that we are TDXD is coming up in a big way in that kind of a spectrum. Now, this one entity of ER low breast cancer, that was one of the abstracts that was actually presented. Now, when pathology reports are generated, a lot of pre-analytical and analytical factors are there, and ER low breast cancer is a well-defined entity as per the ASCO-CAP guidelines. And as you can see here, on the topmost is the strongly ER positive. The third one is actually on the low power. You do not see actually ER expression, but on a higher magnification, you see faint expression of ER. So this is the ER low subtype. Now, let me begin with the first question to the panelist. Maybe you can start from Dr. Warrior. So, how commonly encounter ER low breast cancer in your practice?
Maybe 10 to 15%.
Okay. Anybody else? Vamsi?
I would say around 5 to 10%.
Okay. Others, any difference of opinion from what you see in your?
The similar, I think so, 5 to 10% cases we have found ER low person.
So similarly around 5%.
Okay. So 10% I would say is somewhat bigger actually across the global studies that have been reported. Usually the percentage of ER low breast cancer has been typically around 5% or less. But again, there are a lot of factors that are involved in this. Now, as we all of know, we treat TNBC in a completely different way today. ER positive we treat in a completely different way. And the decisions regarding whether to give a neoadjuvant therapy or adjuvant therapy, whether to give olaparib, whether to give capecitabine, whether to give ovarian function suppression, these are all kind of complete important decisions that we take depending upon that. But what is a gray area is actually ER low, because not many trials included this population in their trials. Very few trials have included the ER low subgroup, and it's a question that actually what we should be do. Now the question to maybe Dr. Jogmaya, you can take this, that in order to determine like whether the patient is truly the patient that I presented, in order to determine whether the patient is truly ER positive or the patient is triple negative, will you do a ER ligand binding assay?
Actually, sir, it is high time that we should look and think beyond the common IHCs, and there should be some other tests which should be available to confirm the reports, like we confirm actually the HER2 results. So like that, I think this should also be
So
in
in
clinical
this, yes.
practice.
So in here there was no ambiguity about HER to new, but ER for ER, yes.
Yeah, sometimes what happens is when ER is borderline, like ER is low, we tend to take a second opinion, ask for another IHC by another pathologist. But if the tissue is not fixed properly, we may not get a reliable report by the second pathologist also. So it's very difficult.
That's true. But actually it is very important also here because your treatment approach is completely different. So Dr. Shaina, your comments on any utility of doing the ligand binding assay?
I don't think we have anything standardized in clinical practice to do this test. And, my counter question would be, how would it make a difference to your treatment? We're still going to say, even if you do an ER ligand binding assay, it'll come back, say, suppose it's positive, this is still an ER low disease. So you're still going to fight in the MDT as to how you're going to treat these patients because we don't have solid data to tell you one way or the other. And now with the introduction of immunotherapy, or the data that we have for immunotherapy in HR positive, it just makes it more complicated. So I don't think that this is going to change how you approach your patient.
Let's say if the ligand binding assay shows that the femtoliters is high, like there's substantial ER expression, then will it change your management?
I think that is unlikely to happen. That means your pathologist completely got it wrong. If one is saying it's ER low and the second is saying it's ER negative, it's unlikely for the ER ligand binding assay to say that it's going to come back as high.
Okay, so you feel that there is no real benefit of doing that. Now, another question, maybe Vamsi, for deciding about management of these patients, is there any role of looking at the progesterone receptor status? Does it make any difference whether in this kind of a ER low population, PR really matters? Now, I'm not talking particularly about this case. Here I clearly mentioned that it was PR negative. But let's say that somebody has ER low tumor and PR is positive. Does it make any difference?
It does. So simple answer, it does make a difference. What difference will matter in practice, I really don't know. We know that if it is ER negative, generally the PR should not be taken as positive, even if it is positive on the report. Having said that, in practice, I think a lot of us would still go ahead and give some form of endocrine therapy for whatever benefit. Whether it is, you will never get a trial on that. So that's my way of looking at it. Even if you get ER negative and PR positive, I would still tend to give a hormone positive. Do I have strong evidence? I don't.
Okay, yeah.
Sir, even in the abstract that was presented, they just mentioned ER low and ER positive. So I was wondering what about the PR in those ER low patients?
Correct. In those studies, they have not commented, I think, on that. Now, what this one study has shown is that those patients who are ER low, if the PR is negative, actually they do more like ER positive and their outcomes are better. Means prognostically they are better as compared to if somebody is ER low positive and progesterone receptor is also positive. This is something a prognostic value. I don't think so you can really determine treatment based on this, but one should know this that it has some prognostic kind of a significance. Any other test that anyone would recommend in order to really refine the diagnosis, like is doing the PAM50 to see the intrinsic subtype of the tumor, or looking at the MRI expression on the oncotype DX assay, or doing BRCA testing to determine the appropriate therapy?
I think the only thing I would do is the BRCA because that will affect the management of the patient in terms of whether you're going to give a laparib or not. I would certainly not do PAM50 or oncotype on this type of patient.
Okay. Anybody has a different take on this? Intrinsic
Maybe
subtype,
so.
because we have seen that basal, like they do inferiorly and they respond better to kind of a triple negative kind of therapy. So
But again, how is it going to affect your management? We don't have data to direct us for therapy. When we do these tests and we expect a certain type of result, we should have data to say, look, this is what you should do for that particular type of subtype. It has not been incorporated into clinical
so let's say
practice.
that you have done oncotype DX on the MRI expression, you are seeing expression of ER is there, PR is there on the oncotype DX, but although here it is ER low. Will that change your management? Now the question is that whether you will give hormone therapy, whether will you give CDK4 inhibitor, that those are the kind of questions that will arise.
on the Oncotype DX report, it's like you said, it's an mRNA expression. Again, we're not supposed to use that in clinical practice. It should make you think about going back to your pathologist to retest. I recently had a patient where HER2 was negative, but the mRNA was HER2 positive on the Oncotype. I went back and retested; it was still negative. The genomic health people also retested; it was still negative. So you can't correlate the two. So that's number one. Number two, I will still give endocrine therapy to anyone that's ER low. The question is using a CDK4/6 inhibitor or not, or using immunotherapy or not. And none of this is going to be able to help you make that decision.
All right. Now, any comments on this study that was presented by Dr. Irma? Anybody from the panel?
Actually, it just making a rough outline is, if it is ER low and you are treating it is in a neoadjuvant setting, we will treat it like TNBC, and in the adjuvant setting when you are giving hormone therapy, you will treat it as hormone positive. These ER low patients, initially we tend to, they are saying that ER low you treat it like TNBC because it is a poor prognosis, like it is a more aggressive disease.
Correct. So this meta-analysis by Pacola, and I think this study also tells us that behavior-wise, those patients who are ER low in terms of disease-free survival and overall survival, they behave more similar to the TNBC. The benefits are more akin to what you see in TNBC as compared to the ER-positive disease. As you can see here from the forest plots, between ER-positive and ER-low, the benefit with chemotherapy is more in the ER-low as compared to the ER-positive disease. And this study by Dr. Irma, actually, this just confirms the several other studies that have been done so far. Now, coming to the next
Dr.
abstract
Ashish,
that...
can I ask, what will everyone do if you get a ER5? I mean, I would still go ahead and give endocrine. What about everybody else? Will you say that it is going to be treated like TNBC? I don't know. What will people do?
We will consider giving endocrine therapy.
Then this discussion is moot. If you're still going to give hormone.
Sir, even in the last study, it was a very small territory study. So we need more studies to actually define the ER cutoff.
So I think in Dr. Irma's study also, they gave about 5% of the patients, they received hormone therapy, but that number was very less actually.
Dr. Bakshi, can I make?
Yes, yes, please.
Yeah, okay. So also it's a known thing that sometimes these markers do change after neoadjuvant chemotherapy. And that is a known thing that happens. So I would like to know from the panelist or even from the audience that after giving neoadjuvant chemotherapy, are we checking the receptor status again?
No.
Because it becomes more confusing that
I have to admit I do check for all my patients. And I think
For all the patients.
who have residual disease, obviously. If you give them neoadjuvant therapy and then they have residual disease, I tend to check. About 30% of these patients, like you said, will have a change in their biomarkers.
Yes.
I've had patients with hormone receptor positive, true hormone receptor positive, HER2 negative, after pre-op therapy in the post-op setting residual disease, I've retested and they've turned out to be HER2 positive. So I've given them anti-HER2 therapy. Similarly, I've had patients triple negative that have gone the other way. So I think it's important to do it. I don't think it's wrong not to do it. This is like an academic exercise that you do with your patients. It's more important when it's negative and it goes into a positive part, because then you have something that you can give your patients. So yes, when I have residual disease, I do tend to test it. It causes, you're completely right, more confusion, but it gives you added information to try and tweak the therapy of your patient. And I think information is always important.
Yes.
Ma'am, when these patients become metastatic, and again we will do a biopsy, and
Yes.
if there is receptor changes, then
Yes.
will that not be more confusing?
I think it gives you information on what aspect of the disease has metastasized. I recently had a patient who was treated elsewhere, triple negative, neoadjuvant, gotten pembrolizumab plus chemotherapy, had significant residual disease post-operatively. Part of the tumor, it was tested again for ERPR HER2, part of the tumor was HER2 positive, so she was put on anti-HER2 therapy. She now has recurrence of disease. I've tested her liver, it's clear-cut triple negative. So it's the triple negative part that's come back, not the HER2 positive part. So exactly. So it tells you how to treat your patient at the end of the day.
So Dr. Shahina, to continue that, so once you have that changed report post-operatively. Would you give that adjuvant therapy based on that report?
I would certainly consider it and put all factors together for the patient.
Okay, thank you.
All right, let's quickly move on to the discussion regarding the epidemiology. Dr. Shonanag's paper, this was already discussed. Now, we all know that we see more TNBC in India, and even in India also there is quite a bit of distribution and discrepancy. So, I was myself surprised that in Nagpur they have reported a percentage as high as 40-45%. Anybody from Nagpur? Dr. Anand Patak is there? So, like, do anyone of you see such high percentage, about 40%, 45%?
So in Eastern India also, like in Kolkata or in Patna, I think in Ranchi we have one paper, we have around 500 patients, and that 40% we have reported TNBC.
All right.
Could I
Dr.
ask a
Shaina.
question here? And Shona is sitting here, so maybe she can answer. In India, you have, and it's also the same in the UAE, you have a very young population of women who have breast cancer, and it's because they're so young. Could that be contributing to why you have a higher percent of patients that have triple negative breast cancer? So, Shona, maybe, or Sudeep, yeah.
So,
Yeah, that's absolutely right, and we mentioned that in our paper as well.
Young people who are getting TNBC, ma'am, but we don't know why they are having this problem. And this is a very remarkable study that has been done in India, because epidemiological studies we don't have that many. And very surprisingly, the visceral fat, the visceral adiposity was associated with TNBC, which is usually for ERPR positive patients.
So I just wanted to say in response to your comment that that's absolutely correct, Shona, not Shona, Shahina. So many years ago in 2011, we published a paper where we showed that triple negative status is age dependent. And in our women who were less than 40 years of age, the proportion of women with TNBC was actually about 45 or 50%. Whereas in the oldest age groups, more than 60 or 65 years, it was actually just 15%. So the fact that we have a higher proportion of women who are younger automatically translates into an overall higher percentage of triple negative breast cancer. So that was a paper which was published by Dr. Jaya Ghosh. She's not
so
here.
sir, one question for you. In the last almost 30 years of your practice, have you seen that this has changed? Actually, so many younger patients we were not seeing probably in the 2000s, and as compared to that, we are probably seeing more. Is that perception correct?
So I would put it, see, the number of patients, of course, is a function of the population. So our population has grown, so the number of patients increase. But I would say that the median age or the mean age of our patients is actually becoming older in almost every cancer. When I was training in AIMS, the average age of patients with breast cancer there, I analyzed one data set, was 44 years. Today it is about 50 or 51 years. And that's just a function of the changing demographic profile of our entire country. Our country has now has increasing proportion of older people, it is still young, but that percentage is growing.
Okay.
Can I just add to this? Let's say that there are two different pathways through which breast cancer is happening in the population. One is related to your inherent genetic risk, where we have more of younger patients, more of triple negatives, and we have that IRCH study where the proportion of inherited mutations is much higher than in the West. And on the other group, we have a environmentally derived breast cancer, which is happening more hormone receptor positive, more in the elderly. So in India, we have still not that much of the environmentally derived breast cancer, which would dilute or change the age distribution, triple negativity. That may be a factor.
I think I agree with your point. Now let's move on. This is a one Mexican study actually with a similar kind of study, a lot of similar data, where they have also not really been convincingly show that particular factors are really linked to the epidemiology of TNBC. I think in the interest of time, I will skip this. Now coming back to this patient. Now, Priya, how will you treat this patient? You will treat this with a neoadjuvant approach or you will treat with an adjuvant approach?
So like we have already discussed that we'll take an approach of this and triple negative approach. So I'll consider an NACT approach in this patient.
All right. Now, coming to the other abstract that was discussed regarding the meta-analysis by EBCTCG. So, which chemotherapy for this patient? Now, on one hand, you have, like, we have almost like 15, 20 different kind of regimens that are available and that many times all of us use in clinical practice. Now, this is the meta-analysis on your right-hand side, and on all of your left-hand side, this is a review article written by Dr. Sarah Hurwitz, and a lot of luminaries in the field of breast cancer are there as authors in this study. And these are the conclusions from this study, which was published in 2021. The following statement is true. As of this writing, there has been no prospective trial that has demonstrated an OS benefit from the addition of anthracyclines to taxane-based chemotherapy in a curative setting. And on the contrary, we have this EBCT-CG analysis telling us that concurrent anthracyclines and taxanes should be used. So, what should we do now, Mamsi?
So I think this EBCTCG, again, when you look into it in detail, the headline is something which is different from what actually the inner things say. You know, headline says give anthracycline to all. That's not what the headlines actually said.
This is not a headline. This is the conclusion of the author.
No, sir, not the only conclusion. That's what I'm trying to say. They have said that TAC is better than TC. They have not said anywhere that TAC is much better than 4AC40. That conclusion is not there in this. You can say that if you're giving 3 anthracyclines rather than you give 6,
if you look at these are the comparisons between TAC versus TC, and lower down are the sequential regimens.
Yes.
If you see the hazard ratio with TAC, it is 0.58, with the sequential regimen it is 0.94.
Correct. So again, my point is, for a single patient who comes to us, where are we using TC? We are using it in that HR positives early breast cancer adjuvant.
So once again, for the sake of clarity, since we are discussing TNBC, let us focus only on TNBC. We will not touch upon HER2/neu and HR positive. So now let's say that
again, do we have anywhere in the meta-analysis which says TNBC 6 TAC is better than 4AC4T? Or 4T with carboplatin? I could not find that analysis.
The benefit is both seen in ER positive and ER negative population.
With TC.
They have not.
With TC.
No, this is TAC versus TC.
Correct. That's what I'm saying. So
this is some whatever 3,000 patient that they had. TAC versus TC. ER negative is equally beneficial. TAC is equally
I will not
beneficial.
use TC in ER negative. That's my point. If it is now a TNBC, I will use AC and T. I don't see the point of using a TAC. That is what I would say. And again, if you remember the ACT, what they have said is if you're using a docetaxel, your cumulative dose should be higher. If you're using anthracyclines, your cumulative anthracyclines should be at least 200 or 300 E. Those are the conclusions
But I'm
of the
playing
study.
the devil's advocate here. The benefit, if you see the magnitude of benefit in terms of the recurrence rate as well as mortality, is maximum with this regimen as compared to all other regimens that they have put there.
So again, if you go back, the regimens they have compared are the EC and T, where they have said that you're using only 3 cycles of E and 3 cycles of T. So that brings you back to the cumulative dose. So again, my feeling is, my contention, if you're giving a full cumulative dose of the anthracyclines, that is at least 4, you're giving the full paclitaxel, which is weekly as per their study. They have said not 3 weekly. Or you're giving a dose dense, I think you're still good. That's my conclusion on reading, but everyone can.
No, this study says that concurrent anthracycline with taxane is better than taxane alone or sequential anthracycline and taxane. And if we have a fit patient who can tolerate TAC and she is TNBC, we can always go for TAC. I mean, we have to consider every patient individually, the patient profile, the toxicity, whether she can tolerate it or not.
Can I ask
Yes,
a
of
question
course.
here? In 2024, how valid is any of this data? This patient has practically triple negative breast cancer. You showed a report where it was all ER/PR negative, so I'm going to just say triple negative at this point. In a triple negative breast cancer patient who fits the criteria of Keynote 522, you do Keynote 522, which is Taxol, Carbo, AC, plus pembrolizumab. If pembrolizumab is not something you can afford, we have data that says adding a platinum is important in these patients with triple negative, which this meta-analysis has actually not even addressed. So I think in 2024, we need to put things into context. This is very good data. It's telling us some information. But in triple negative, in 2024, we're not going to approach our patients like this to begin with.
Correct. So these are the on the table you can see actually both the neoadjuvant data with carboplatin as well as the adjuvant studies with carboplatin, and all of these studies have clearly shown that there is an improvement in pathologic CR rates when you add carboplatin. There is an improvement in the event-free survival in the phase 3 study. Disease-free survival and overall survival also is better with the addition of carboplatin.
So just one query here.
Yes.
So like we just discussed about the 3-drug regimen. Frankly, I have not been using that because of the toxicity. So is anybody convinced that, is there any patient population where we are now seeing the data, you can actually use it?
You mean the TAC regimen?
The TAC regimen.
Whom will you use?
Yes.
Yes.
After seeing this data, the 3-drug regimen data, after seeing this meta-analysis?
Yes, I think it's an important question. Hardly anybody I would say.
Then, if you're using 3-drug, do you make it 4-drug then? Like,
No, that is not the question. See, the meta-analysis had all kinds of patient, right?
No, my question, and in a TNBC, if you want to give carboplatin, then 3-drug is out of question. It has to be Taxol carbo followed by AC or AC followed by
So
Tax
anywhere
carbo.
in breast cancer, the 3-drug regimen, if not just TNPCs, if you're talking about.
So in my view, you cannot say that you cannot give a 3-drug regimen in triple negative. There are 3 and 4-drug regimens in
I'm
triple
saying
negative.
one question is, you have to clarify first, are you convinced with carboplatin, yes or no? If you are convinced with carboplatin, then there are 4 drugs you need to accommodate. We cannot, TAC is then out of question, right? That's the only point.
So the question is that what we do not know is that, let's say if you give TAC and add pembrolizumab to that, will that make a bigger difference? Nobody knows
We
that.
do not have that data, and that should not even be questioned.
I think what she was asking was outside the realm of triple negative. Say in hormone receptor positive, would you use TAC? From my practice, I don't use TAC. So. Pardon? That's docetaxel cyclophosphamide. We use that in high-risk node-negative patients with, say, oncotypes that comes back where you can use that in the adjuvant setting. But TAC, we haven't really used that a lot.
So Dr. Shaina, let me ask you a question. Like you have a patient with breast cancer who has 29 nodes out of 42 nodes positive that have been removed. Which regimen will you use? ERPR positive, HER2 negative.
So first of all, anyone that has that many lymph nodes is basically metastatic disease. But having said that,
it is confirmed on PET scan. It is not metastatic.
But
and these are not very uncommon scenarios. Actually, these are something that we see fairly common.
Again, I'm going to say in 2024, none of these studies have considered that now we use adjuvant CDK4/6 for these patients. So I think it's reasonable using AC followed by T. The main risk reduction comes from your endocrine therapy plus the CDK4/6, which this patient would be a perfect candidate for.
So you are dismissing completely the results of the EBCTCG analysis.
I'm not dismissing it. I think it's very important data. It's telling us how to plan our future trials, but I don't think it's applicable in 2024.
All right. So there is one meta-analysis for carboplatin versus no carboplatin. This has been done by Ames group, and they have shown there is a benefit in terms of the disease-free and overall survival. There is one more meta-analysis, and that has similar results. Now coming back to Sudeep sir's study, this was presented last year at San Antonio, the TMC neoadjuvant platinum study. This has clearly shown that pathologic CR rates are more when you add carboplatin. And the event-free survival benefit was more in the group of patients who were less than 50 years of age. And similarly, the overall survival benefit was not there in patients who were more than 50 years of age or who were postmenopausal. Now the question to the panelists, maybe anybody can take. Dr. Srivastava, where is he? Yes, you have been quiet. So in this patient who's 52 years of age, let's say she's TNBC, will you use this regimen?
Yeah, presently we are using this kind of regimen, including the platinums in the neoadjuvant settings, and but my sequence is AC followed by paclitaxel plus carboplatin, what we are using in that, and clinically we are finding the better responses when we are not using platinums and now when we are using the platinums, when we are comparing.
So, Sudeep sir, I have this question for you. That first, what is your advice to the audience that based on your experience, what should one do? Like if the patient is more than, say between 50 to 60 years of age, should one be adding carboplatin or no?
So that's really a difficult question. And, I presented this study. We still don't know. And I was having this discussion with Dr. Ho Prugo just about half an hour ago as to why this result is there, why postmenopausal women or those who are older did not seem to benefit, but it's a very sharp, you can see that there is a concordance between the PCR results as well as the survival results there. No benefit in PCR, no benefit in survival in the older or postmenopausal. The way I look at it is, 50 can't be a sharp number, biologically speaking. Somebody who's had their 50th birthday day before yesterday can't then just stop having the benefit from platinum. So the way I look at it is the closer they are to their age of menopause, I tend to use platinum. This would have something to do with menopausal status, biologically speaking, rather than a number as age. So I tend to do that, but given this data, and this is this data I have analyzed repeatedly, I thought about it. Similar data also exists in the CALGB trial and in the brightness study. It is just that they have not highlighted it. It's in their supplementary appendix. If you look at the benefit in younger and older patients, I do tend not to use platinum if somebody is older than 60 or 65 years of age.
Can I ask, because
But
since you're there,
having said that, so the results of this study would of course not be applicable if one was planning to use pembrolizumab, because there is no data to say that one should use pembrolizumab without platinum.
So I'd like to ask you another question as well, since you're here. And just to let everyone know that I used to argue with him about using platinums prior to, he never used to use it prior to the study. Two questions actually. When I looked at the data, phenomenal data, but can you explain why there was an overall survival advantage, which we didn't see with Keynote 522, and we're still waiting to see that overall survival? And number two, the path CR rates are very similar to what we are seeing in Keynote 5. We shouldn't do cross comparison of trials. So my question is immunotherapy even needed?
I think immunotherapy is needed, but in order to be able to answer that question, one would need a trial where you have platinum in one arm and immunotherapy in the other, and no platinum in the other arm to be able to answer that question, and we don't have that trial. I think the reason why we showed an overall survival benefit is because this was a real high-risk group of patients. So about 88% of the patients were clinically node positive. I think if my memory serves me right, about 60% of them had either T3 or T4 tumors, N0 or N0 to 2. So these are not the kind of tumors that were randomized in the Keynote 522. What in the Western countries they think is locally advanced, they don't even begin to see the actual locally advanced breast cancers that we see. So I think that, given the high event rate and the high risk, I think that is why we proved the overall survival benefit.
Which is why I feel that all triple negative breast cancer patients, if you can't use pembro, which is so expensive, carbo is cheap. And you get that PCR that you want, and patients actually do very well.
Dr. Bakshi, can I just a minute?
Just quick, because we are running out of time.
I need one more insight on this. There is an interesting, unambiguous flip of the curves. Age is an important clinical parameter here. Is there any further molecular insight into looking at the platinum sensitivity below 50 and above 50? Is that this thing? And androgen receptor is missing in the discussion.
So you are absolutely spot on that there must be a biological reason either in the host or in the tumor that would account for these results. So currently we are doing a study with Professor Andrew Tutt of UK, of the Royal Marsden. And what he suggested is that perhaps we look at the epigenetic modification of BRCA1, BRCA2 and the other genes in the HRD pathway, and that might be different by age or by menopausal status, and that might account. So essentially BRCA-ness, if not BRCA. And I have to add here that in the brightness study, they have analyzed the benefit of platinum by BRCA status, and there actually they found that there was no correlation with the BRCA status. So the short answer, that was a long answer. The short answer to your question is that I don't know. Nobody knows the answer.
So I think we will move on with the chemotherapy discussion. Some questions regarding the immunotherapy. Dr. Shaina, you asked this question yourself. That do all patients need it? So now to reframe my question, if there is one patient in whom you want to avoid immunotherapy, which is that patient?
So, we all get patients with triple negative, node negative patients who come in with low Ki67. They're clearly triple negative, but they're low Ki67. I'm sure that if you immunotype them, which you want to do, and they turn out to be AR positive or non-basal like type, that would probably be the one type of patient, small tumor, low Ki67, indolent type. I probably would think, why am I using immunotherapy? Would I not use it? No. I would use it based on the criteria and the approvals that we have. But that would probably be a patient that I'd take a step back and think, should I even be using immunotherapy here?
So I think because almost like 70% of the patients are doing well without the immunotherapy also, like they have been cured. So definitely when we are giving immunotherapy to other patients, we are over-treating. The same problems we are facing now, what we face with the both trastuzumab as well as the hormone therapy.
But as you saw in the last interim analysis of Keynote 522 that was presented in San Antonio by Peter Schmidt, you can see that even in the PCR groups, now you're beginning to see a slight separation in the Kaplan-Meier curves, benefiting the patients who were taking immunotherapy. There was 4.4% in the node negative and about 3.6% in the node positive. It's not statistically significant. I don't know if it's a play of chance, but I would want to wait for longer follow-up because there may be a benefit to actually using immunotherapy. As I said, the PCRs may not be the same.
Okay. Anybody from the panelist, is there any role of low-dose immunotherapy like we have been using in head and neck cancer? Has anybody given a thought about it?
Tata Memorial should do another study and publish it, sir. Then we will know.
But I think that will be an interesting question to answer.
So can I just ask one question to Shahina, because you said you showed the results of Keynote 522 and whether pembrolizumab was required after attainment of PCR. I personally think, and I may be wrong and I may not have the entire data to back me up, that the baseline risk prior to starting neoadjuvant chemotherapy should also be taken into account while deciding whether to go on with immunotherapy beyond PCR or not. So for example, if I gave neoadjuvant immunotherapy and chemotherapy to somebody with a 2.1 centimeter tumor versus a 6 centimeter tumor, I think maybe those two should be treated differently, node negative versus a node positive patient.
So I completely agree with you. Not all PCRs at the same stage does matter at baseline. But I'm actually not talking about whether you should be using adjuvant or not. I think Japrinuvo makes you think that is after you attain a PCR, do you need to even continue immunotherapy? That's a separate question. I think the question he was asking was, are all PCRs the same? If you attain a PCR, do you even need neoadjuvant immunotherapy to begin with? So if you have a patient that you can predict has a 90% probability is going to get a PCR even without immunotherapy, why would you add immunotherapy? That's a different question.
Then let me ask you this question. Suppose you have a PCR with pembrolizumab and chemotherapy. Would you continue with pembrolizumab beyond that time point or not? And if yes, in whom, and if not, in whom not?
So first of all, if my patient had financial difficulties, I would be very happy to stop the immunotherapy. I simply don't know if it's good or bad, but it seems to me these patients are doing well anyway. But if you told me right now, who would you select to continue? I would say at least those patients who are node positive, big tumors, that like the types of tumors that we see in this part of the world, those really bad triple negatives, I'd be more inclined to continue. Is it actually benefiting them once they attain a PCR? I don't know, but I'd be more comfortable continuing at least in that group of patients.
Okay, Nitesh, quick question.
One. Then what about the role of MRD with same kind of person?
So actually, that's a very interesting question. There are trials going on right now to check and see if MRD can actually help you select who should and shouldn't receive additional therapy, not only immunotherapy, post-operatively. We have to wait for that data, Nitish.
So anyway, I
Can I
think
ask you
we
one question?
are running short of time. Yes. You
How
will have
many?
to give
How
me
many?
5 minutes more.
How many are using chemo combination as a new adjuvant setup TNBC day-to-day basis?
Let me qualify it. I think we are offering it to a lot of patients at least. Not all of them can take it. Mostly they cannot take it. But we are offering it nowadays for the for the triple negative.
And yet not tried the low dose, though tried in other cancers, but not in breast.
Dr. Ashish, we have got 4 minutes left.
Yes. So I think couple of important issues to be discussed. Contralateral breast cancer, that abstract was actually presented. This patient, as you can see here, I am not going into the details of the case, but underwent MRM, and almost 10 years later on, this patient has developed a contralateral breast cancer. Now, this study was presented in the morning actually, which has shown that those patients who are BRCA positive with radiation, they are at a higher risk of developing a contralateral breast cancer. Now, what is your take on actually utilizing Vamsi? Maybe you can take this. Any utility of actually doing, because in any what I feel is that in any case you are monitoring the patients for contralateral breast cancer. So what difference does it make? Ideally, you are with BRCA population, you are supposed to do an annual MRI. So will that change really this change the management of your patients?
So I think all these help you because you can prognosticate better. If you have a high risk, you will tell the patient, look, there's a high chance of developing. Please go for a risk reduction mastectomy. So I think it helps. Are we going to do it in real practice? I doubt. I'm very comfortable kicking the can down to the genetic counselors and letting them handle it. So that's what I'm doing in practice. But ideally, we should do something like this.
Okay. I think the acceptance of contralateral mastectomy is very low in our country. That has been my experience. I mean, we have been discussing this with our patients, but hardly anybody.
So again, I don't think we are really been trained or qualified to do it. It's better to let someone spend, say, 5 hours sitting with the patient and talking to them rather than the 5 minutes that most of us can give.
Okay, I have my different take on this, but anyway, all right. So again, the location of the lesions matters and all that, which was not actually shown, but those patients who have BRCA mutation in the 3' region, they are actually more at risk of developing contralateral breast cancer. Now, quickly coming to the role of maintenance capecitabine, like we know that from the CREATE-X trial. Now, the question is that, is there any utility of doing a ctDNA? Dr. Satish, is there any utility you see in doing ctDNA in the management of breast cancer, as Nitesh asked this question of doing MRD?
I have been not been personally using ctDNA, but we have this thing after post-capecitabine, people have used for monitoring it.
So actually this abstract was not presented today, but I think it's a very important and interesting study. We need more data, but again, in this trial, in fact, they showed that those patients who were ctDNA positive post NACT, many of them did not clear their ctDNA with capecitabine. So probably this is something that will need more kind of study. Now, again, are you confident, is anybody confident in using this fixed dose regimen in those patients who are receiving the post-neoadjuvant capecitabine? Will you use that?
This
Do
is
you have the
fixed dose of
confidence?
1500 BD. I don't think we use 1500 BD anyways in most of our patients. So I think it's just, it's nice, but I think this is something in practice most of us are doing. We're dose modifying, date adjusting, doing all that anyways.
All right. I think metronomic dosing has been discussed. So I think, let me quickly summarize. ER-low breast cancer is a distinct entity, more akin to TNBC. More dedicated research on this phenotype is required, and I am sure in the times to come, we'll see more studies like that. TNBC has a distinct epidemiology, particularly in India also, as has been elucidated by Dr. Shonanak's paper. Choice of chemotherapy is a complex process and should always be individualized. Neoadjuvant therapy is a standard of care. Carboplatin should be included in the neoadjuvant chemotherapy regimen. Achievement of pathologic CR is important, I feel, and that those patients who have pathologic CR, they have a better outcome, as has been already presented. Immunotherapy has become a standard of care. Optimal duration of immunotherapy is not clear. How many cycles you give post pathologic CR, whether one should give or not, if, say, for example, for how long duration, all those questions are not clear. Newer combinations of immunotherapy with, say, other immunotherapy drugs or antibody drug conjugates are currently being studied, so we'll have to wait for more answers. Maintenance therapy is a standard for those not achieving pathologic CR, so you give capecitabine or olaparib depending upon the patient's profile. Alternative schedules of capecitabine can be considered in patients with metastatic breast cancer. In my view, this is not to be done for patients who are being treated in an adjuvant setting. Patients should be monitored for contralateral breast cancer, and I think ctDNA is a promising tool, but of course more research is needed. With that, I think I will conclude my talk.
Can I take
35
a quick
seconds
take
before.
on one? Can I take one quick take on the other way around, like omitting pembrolizumab? So if there is a patient with high-risk TNBC who did not receive pembrolizumab somehow in the neoadjuvant setting, has landed up now with residual disease, would you now offer, like we don't have evidence, but would you still offer any taker for that?
I would not offer it at this point. We don't have the data to support it. I think it's more important to change the chemotherapy at that point and to give capecitabine. That's what I would do, and to test for BRCA and to give olaparib if the patient
Say
was a
if the
candidate
patient is
for it.
BRCA negative.
So then
and,
capecitabine. I would not add
not add.
pembrolizumab.
Hello, Dr. Srinath. Just I want
Okay,
to
thank you so much.
just
Thank
one
you,
last
everyone.
question.
Yes, sir,
Okay,
please.
So basically, you're talking about the low ER status and the ER strong positivity, but many patients, about only 70% of the patients respond to the tamoxifen or AI with ER strong positivity. But 30% of don't respond. So there is some component of functionality has to be checked out. So rather than going only with the ER positive, low, high, are there any methods by which we can check into the functionality of the estrogen receptors, whether that can work?
You're talking about in the neoadjuvant setting?
Yeah, no, functionality of the estrogen receptor.
So just let me give you an example. Let's say for example, in this kind of a population, any utility of doing FES PET CT.
Correct.
If FES PET CT says positive, what
Yes.
will you do?
Estrogen stimulation of the estrogen receptors and
They-
doing a
it's,
scan.
it's not. This is all experimental. I
Absolutely.
think it's very interesting research. I know what you're talking about, but in practice, I would not do it.
All right. Okay. Thank you
Thank
very
you.
much. Thank you, Dr. Shaina. Thank you, all the panelists. Thank you.